All right, so next we're going to talk about hypoglycemia. It's caused by either too much insulin, not enough food, sometimes too much exercise. So we've got to balance how much glucose is being used, how much insulin is being given to allow it to be used, and how much glucose is being taken in. What does it look like? So early on, they may feel shaky, anxious, may look a little bit pale, tremors, palpitations, sweating. They may be hungry. They move past that stage and start to feel weak. They may feel nauseated. So they move from hungry to now sick and it's hard to eat. They may be dizzy, have a headache. They may be drowsy, irritable, irrationally irritable sometimes, like yelling over silly little things, loss of coordination, seizures, and coma. So hypoglycemia can progress to fatal. If we are not sure if a patient is hypoglycemic or hyperglycemic, we need to test the blood glucose. If we're not sure, we don't have a way to test, we want to give a simple carbohydrate. If it's low, they'll respond to that. If it's high, we make them a little bit higher. Low is going to kill them first. Okay. For mild hypoglycemia, milk or fruit juice is usually enough to bring it up. For moderate to severe hypoglycemia, they may need a simple form of sugar, candy, icing, glucose tablets, or gel, something like that. That always needs to be followed either way. If we just give some juice or milk or some candy, it always needs to be followed with a snack that contains complex carb, protein, and fats. So we have someone whose blood sugar is low. We give them some sugar, it jumps up, they feel better. They probably don't feel great, but it jumps up. We don't give them anything else to follow that, they will drop back down and then they get on the zigzag. Okay, so we want to get them up and then give them a snack that has complex carbs, protein, and fat to stabilize that blood glucose. If the patient is unable to swallow, there are two options. D50 can be given IV if they have IV access. It's best given in a central line because it's very hard on the veins. It is basically sterile simple syrup. If you've ever seen simple syrup, it is 50% dextrose, 50% water. That's what we're giving. This is just sterile for IV use. So it irritates those veins a lot. If you give a couple of doses in a peripheral IV, they're going to have phlebitis in that vein most likely. So it's going to damage the veins. Do we always have a central line when we need to give D50? No. If you give D50 in a peripheral line, you should prepare to look for another IV location. Sometimes you can get by with one dose. I've not seen 2 doses given in the same IV without having to resite the IV fairly soon after because it causes phlebitis. If they don't have IV access, glucagon can be given. Glucagon injection. Remember that glucagon causes the glycogen, which is a storage form of glucose, to break down into glucose. So someone is unconscious, have a blood sugar of 20, we give them their glucagon, their blood glucose comes up, they wake up. When they're alert and can safely swallow, we want to follow that with frequent small amounts of sugar containing fluids. Once they're able to eat, we want to follow with a simple sugar, and then we want to follow with a snack with complex carbs, proteins, and fats. They're going to be exhausted after all this. Now, say they've used their glucagon and they come up some and then they drop again. Can you use the glucagon again? Probably not going to work because they have broken down their stored glycogen. They haven't had time to rebuild that glycogen store. So we need to make sure that patients understand that glucagon's not magic. They can't just keep using it over and over. It's an emergency response. Patients who've had a hypoglycemic episode, we need to continue to monitor them because that may happen again. That may recur. Okay, next section, we'll talk about some long-term complications. You know, before we end the section, I want to talk about one more thing. One of the things that I see frequently, people who are managing hypoglycemic episodes, they are connecting their blood glucose to how they feel. And low blood sugar does actually cause you to have some symptoms that are very uncomfortable. You feel weak, dizzy, sick, tired, nauseated, grumpy. When the blood glucose is back up to normal, the symptoms don't necessarily go away immediately. So sometimes we see people who really overshoot that. They will just they want to keep eating sugar until they feel better because they think they're still low as long as they still feel bad. So we can also educate patients that if you've had a hypoglycemic episode, even when you need to check your sugar to see if you're better, check it frequently the rest of the day to make sure it doesn't drop again. But even if you still feel bad, that doesn't mean your sugar's still low. You're probably going to feel bad once it's up for a little while, often for the rest of the day. So that's one of the ways we can help patients avoid getting on that roller coaster. Okay, next section, we'll talk about long-term complications.